I'm Miguel Saps. I'm professor of pediatrics at the University of Miami and the chief of Pediatric Gastroenterology, Hepatology, and Nutrition. This is a picture from where I live. So I want to say thank you to everybody for listening today and for tuning for this lecture. So in the next few minutes, I will talk about the importance of abdominal pain, some concepts that I think that are important to underscore, and also why should we have interdisciplinary treatment for children who have these symptoms. So first, I want to get you familiar with some terminology that you may hear when you go to see your pediatric oncologist or your pediatrician. Some of the terms you will hear is functional gastrointestinal disorders or disorders of gut-brain interaction. Using terms. Those are terms that we use for the presence of symptoms that sometimes are very painful, very disabling, very with a lot of discomfort, but that may not have an organic cause. They may not have something to find, but can be explained by nothing to find in the testing, but can be explained by an imbalance of your body, by altered connection between the brain and the gut. And although those are symptoms that frequently are referred just to the gut, like abdominal pain or constipation or diarrhea or nausea, they result from the imbalance between the relation of the gut and the brain. So this is a complicated concept, but it's important to understand because that explains why do we frequently use treatments that are not just based on GI symptoms. So I mentioned you will hear these terms, and you may hear the Rome criteria, and the Rome criteria is a diagnostic criteria that will help your pediatrician or pediatric gastroenterologist by asking you some questions, either to you and to your children, or to your children, and come up with a diagnosis that not necessarily may be secondary to using testing. Frequently, just with the questions that they will ask you and with a thorough exam, they may be able to come up with the diagnosis. One of the things that sometimes not recognized is how frequent abdominal pain is. Long time ago, we did this study in a school in Chicago, and we found that almost 4 in 10 children will have abdominal pain any single week of the year. So this is extremely frequent. Sometimes parents do not know because these are not social issues that socially we share sometimes with other families or in our conversations. It's not common to share, my son or daughter have abdominal pain and they have diarrhea. These are things that frequently are private, but they are shared to the pediatrician, the pediatric gastroenterologist. But be assured that this is very common. As I mentioned, we need to understand this as this balance of this connection between the brain and the gut, as you can see in the right. And it's important to understand that although we are pediatric gastroenterologists, the problem may not be just limited to the GI system. Patients may have symptoms that may exceed just what constitutes the gastrointestinal tract, not just abdominal pain, not just nausea, but may have symptoms that affect other systems. And that's sometimes confusing, but I want to share with you and assure you that this is very common. We have done some studies also showing that not only is common, but patients who have more symptoms, that they have other comorbidities, other symptoms besides abdominal pain, frequently they present to the doctor. This is common, and this is something that we know how to deal with. Up to almost 3 in 4 children who have abdominal pain will have other complaints. So sometimes, again, it's confusing because the child complains of abdominal pain, but other day complains joint pain or may have headaches, and those are common, or may have some difficulty sleeping or other problems. And I just want to let you know that what may happen to your son or daughter is not unique. This is really common. In fact, headache is 9 times more frequent in children who have abdominal pain than other children. This is a study conducted in a school in Denmark. Also, these children frequently have more emotional symptoms. Because I told you that there is a relation between the brain and the gut. Stressors that may happen to the child may also result in symptoms. Sometimes, unfortunately, some children are bullied. That's not the norm. It's common. And children who are bullied may have more abdominal pain or other complaints, other pains that they may or may not share with the parents or with the doctor, because this, again, seems to be something they may not want to share. They may be afraid. That's something that the doctor will try to elicit in the conversation. Other children may have, and it's not the norm, it doesn't mean that everybody is, but many of the children, they are perfectionists. They try to please the parents. They try to be the best. They try to have the best grades, to be the best in sport, the best in academics. And there's nothing wrong with that, but sometimes that takes a toll in the child, and that results in maybe a stressor that sometimes results in pain, including abdominal pain. Other children, as a result of having so many activities, or because of the pain, or for other reasons, may not sleep very well. And that's something that you need to share with your pediatrician, because if we don't improve the pain, the sleep, sometimes the pain doesn't get better. So there are many factors that they are maybe associated with a poor outcome, with not doing so well. Among those, they having the most symptoms, having depression symptoms, other symptoms that the doctor will try to. But one of the things, the most important things I want to share with you, is that despite the complexity of this, the enormity that seems to be at a certain point, that seems to be desperate, that nothing is going to make them better, that the child is not going to be better again, that's not true. There is hope. And there are a group of experienced neurogastroenterologists or pediatric gastroenterologists that they can help you take care of your child. And I want to assure you that most of the kids will. The basis of that is having finding the right doctor and having the right connection with your doctor, having a good doctor-patient family connection, a frank connection in which you can tell the doctor is available for you, and we can share what happened to the child, doctor's recommendations. And recognizing, I'm sure your doctor will do this, at least should do this, to understand that not two children, they're not the same. The situation that may happen to a particular child may not be reproduced, may not be exactly the same that happened. That's why it's so important to take a history and to try to find out all the factors that may be associated with the pain. It's important that you tell, and the child tells, and the doctor asks, what brought you here? What's most bothersome? How can I help you? How can I make your life better? Because after all, the most important thing is that the child goes back to have normal activity. Pain is important to improve, but most important is to improve the child's quality of life. The child to be able to go back to having fun, to be happy, to play with his friends or her friends, to go to gym, to go to do whatever they want to do. We have the responsibility, you as parents and we as physicians, to help your child to be happy and to have a normal life, even if there is some remaining pain. Some remaining pain may not be the main issue that you are going to attack, that you're going to focus your consultation, but making your child happy and have a normal life again. It's important that part of this consultation includes education, understanding all this, something I'm trying to do in a very summarized form, but you can do it in a longer way with your physician. Engage the family. The physician cannot do this alone. We need to, this is a partnership between the parents, the child, and the doctor, and all together, all of us together as a team will get the child better. And we need to empower the child. We need to allow them to get better and to help them to get better and to have all the abilities back to cope, to deal with their symptoms and to improve their daily life. The things that sometimes we encounter is that there is a lot of information on the internet, and sometimes some of it is good, some of it is not as good. And sometimes there is a lot of pressure to the doctors to conduct a lot of testing. To tell you the truth, in most cases, testing may not give a lot of useful information, but that's something that your own physician, again, depending on each child, will decide how much testing, if any, is needed to come up with a diagnosis. Because we know that keep doing more testing and trying to find something weird, some weird diagnosis that maybe your child doesn't have that weird diagnosis, have one of the most common diagnoses, the ones I'm addressing, like functional abdominal pain. Something that you're not going to find anything on endoscopy, something you're not going to find anything if you do repeat CT scan or MRIs or ultrasounds or other type of studies, but maybe it's as easy as to have a good history. And maybe that sometimes is enough to come up with a diagnosis. So we need, in this partnership with the doctor, we need to allow the doctor to come up with a diagnosis without having too much pressure to conduct more and more testing that sometimes are confusing. Because at the end, only a minority, many of the people, they get information from the internet, and few of them, let's say diet, they get information from the physician, and that is really important. So you should address the questions, and the doctor has a responsibility to give you, to answer what's the data, what's the evidence, what studies are around there to sustain each of the treatments that are available. Because there is a lot of information going around about the importance of diet. I'm not saying that's not important, but again, in each case, we need to see how important is diet in each particular patient. It's not always a diet. It is sometimes, but we need to know that excluding more and more food frequently is not the answer. In general, if you have found that a particular food was excluding that particular food was the answer, you would have excluded by now, and then the child would be perfect by now. And if it's not, it's because diet may play a role, but may not be the only thing that's important in the treatment. You're going to hear many diets, and the one that there is more data is the low FODMAP diet. It's not applicable for every case, but some cases, and your doctor will help you with that. There are some natural compounds that can be used. And again, the doctor will decide which ones are the best for your patient, for your child. But one of them is peppermint oil that has been shown to be helpful in some cases in children who have IBS or even adults with abdominal pain symptoms. Go into other drugs, because after all, many of these drugs, and we need to remember that some of them are natural, they come from the same plants as peppermint oil, and among those is antispasmodics, the ones that they soothe the intestine, that relax the intestine. That's usually the first line. I cannot tell you what's the best for your child because it's a generic lecture, but I tell you that frequently these are drugs that I use a lot in many of my patients. You may hear other drugs, ciprofloxacin. It's a drug that frequently we use for abdominal pain, for nausea. Also, it's used to increase the appetite, to improve the appetite, and that may have a role in some of these treatments. You may hear, and this may be confusing, the use of antidepressants. Frequently, we use antidepressants not because your child is depressed, but because the antidepressants may help to improve symptoms, may help to improve abdominal pain, may help to improve migraines, other pains. So that's something you may hear, and ask your doctor, because whether this, in case the doctor brings up this medication, why does he or she thinks that this is the best medication, and whether there are black box warning to the use of these medications. It has been shown that some of the medications, some antidepressants, improve quality of life. And also that may improve abdominal pain, like in this study. You may hear other antidepressants. Some of them they use for anxiety. And again, although this seems confusing, if you remember that we started by saying that there is an imbalance in the relation between the brain and the gut. The brain is part of it. So sometimes we use medications that are not only directed to the treatment of the gut. There are some antibiotics. Sometimes there is too much going on, too much talk about antibiotics and an alteration of the brain, of the flora. It may happen in some cases, and your doctor again will tell you if he or she thinks that's what happened in this case. There is some evidence for some antibiotics, but not for all of them, and we need to be cautious before using these medications. The use of probiotics is also very popular. There is some data, some evidence from some studies that some probiotics are useful, but remember that these are not regulated by the FDA, and therefore sometimes we cannot rely completely on what they say that they have, because there is no control by the FDA. Still, we frequently use it, but again, I would discuss with your doctor if these are appropriate to you. I mentioned and this has been a repetitive theme of this conversation, that there may be anxiety, there may be depressive symptoms, or maybe an imbalance between the brain and the gut. So frequently we use treatments that focus on the brain. And that's the case of talk therapy, cognitive behavioral therapy. That has been shown in many studies to be useful, although you need to find the right psychologist to take care of the child, somebody with experience in children and the treatment of functional abdominal pain disorders. Because it's not that we don't believe that your child has the symptoms. They do. Otherwise, I wouldn't be talking about this to you. Otherwise, you wouldn't be consulting the doctor. Otherwise, the doctor wouldn't be taking the time to listen to you. We all believe that the symptoms are real. So the psychological treatment is not because we don't think that's true. We know it's true. It's just that they can help to reframe, to see differently, discussing with the psychologist how to react to the pain, how to conceptualize the pain, how to think about having pain and other things that can be discussed in the consultation. It's something fairly new, only 2 years old, that is a device that has been approved by the FDA for the treatment of IBS, irritable bowel syndrome in children. And this is the only treatment that has been approved for this treatment, and then for this type of disorders. And this is a device that is placed in the ear. And although it seems weird that you use something in the ear in order to treat abdominal pain that's far from the ear and it's far from the brain, but through the ear, they can send electrical impulses that will affect the way that the pain is perceived, the reaction to the pain, and that has been shown to be helpful in irritable bowel syndrome and other abdominal pain disorders. Fortunately, this is not available in all centers, but it's something that we're using more and more. We also use hypnosis. This is not the hypnosis that you see in TV. This is hypnosis that is done by certified hypnotherapists, either doctors or nurse practitioners or psychologists who have taken the training to do hypnosis for children with these type of disorders. It's available. Unfortunately, it's not available everywhere, but it's something to discuss with your pediatrician. This may not be the only treatment, but it may be added to another treatment, maybe the only one. And there are studies from Europe and from the US showing that children who have hypnotherapy, who undergo hypnotherapy for abdominal pain, they do better than those that they have standard treatment. So how can we try to understand so much information that was given in only a few minutes? It's very difficult. Very difficult, like to understand all the literature in a 15-minute conversation. But let's try to summarize. We need to understand that this is a disorder that affects the gut, but also have implications in other systems. Patients may also have other complaints, other somatic complaints, other things may hurt. They may have emotions may be altered. Maybe stressors. There may be a relation that we need to take care with the family. There may be different factors. But this is it shouldn't surprise us. We are complex human beings. And we need to look at all the aspects of the child and the family and the relation with the peers and the children and the teachers and everything in order to understand what happened to that particular patient. And then it's the responsibility of the physician working with the family and the child to put all this together. And for that, sometimes it's not enough one pediatric gastroenterologist or one pediatrician. Sometimes you need a team. In most complex cases, you need a team of different specialists that may work in all these aspects, in the biology, the psychology, and the social factors, in all these symptoms. And frequently, and unfortunately not as frequent as we would like, you can have a team of specialist pediatric gastroenterologists, nurses, dietitians, psychologists, social workers, experts in some complementary therapies, pain specialists, and teachers sometimes working together in order to help in an interdisciplinary way. So working all together, trying to put all the heads together and trying to understand all the factors that affect this particular child in order to help them to get better. So this I want to thank, but most importantly, the message I want to give you today is that there is hope. This can be taken care. This seems to be overwhelming many times and seems to be a desperate situation, but frequently it's not. You just need to get with the right team, to have the right approach, to understand your child, and to have a treatment tailored specifically for your child and the problem that he or she has. With this, I'm going to thank you and for your time and for taking the time for listening to this lecture. Thank you.